Every year, millions survive major surgery only to suffer from perioperative neurocognitive disorders. Preventing this cognitive decline is a primary clinical imperative. We must tightly control the brain's electrical activity, maintaining a smooth, uniform alpha rhythm while avoiding jagged, chaotic disruptions. A common misconception in surgical planning is that chronological age dictates a patient's cognitive risk. A healthy 80-year-old and a frail 60-year-old do not face the same physiological hazards under anesthesia. The true driver of postoperative cognitive decline is phenotypic vulnerability. We must look for specific, measurable traits of physiological frailty and existing baseline cognitive deficits. Effectively protecting the brain requires us to identify this exact vulnerable phenotype before the patient ever reaches the operating theater. This identification relies on an extended preoperative evaluation, specifically dedicated to cognitive screening. Anesthesiologists have several validated tools at their disposal, including the Mini Mental State Examination and the MoCA, Short Bless Test, and MiniCog. The traditional MMSE takes up to 10 minutes to administer, is restricted by copyright, and frequently fails to detect mild cognitive impairment due to a prominent ceiling effect. The American College of Surgeons instead recommends the MiniCog as the superior frontline tool. It takes less than 3 minutes to administer and holds a highly predictive value for postoperative delirium. The scoring is absolute. On a 5-point scale, a MiniCog score of 2 or less clearly indicates baseline cognitive impairment. Utilizing rapid, highly predictive screens removes logistical barriers of time and complexity. Universal preoperative brain screening becomes a practical reality for major surgery. Cognitive testing is the first pillar. The second essential pillar is a standardized frailty assessment. This matrix tracks 2 variables. On one axis, a MiniCog score of 2 or less. On the other, a clinical frailty scale score of 4 or higher. Crossing either danger threshold immediately classifies the patient under the vulnerable brain protocol. Triggering this flag dictates immediate clinical consequences. It mandates advanced intraoperative electroencephalogram monitoring, strict hemodynamic targets, and specific neuroprotective pharmacological choices. These preoperative scores replace subjective risk estimation with a strict, objective, and mandatory intraoperative protocol for patient safety. Once inside the operating theater, the first major clinical decision is choosing the primary anesthetic modality. There is a pervasive clinical assumption that neuroaxial anesthesia, like a spinal or epidural, is inherently safer for the vulnerable geriatric brain than general anesthesia. Current meta-analyses demonstrate clinical equipoise. Neither general nor neuraxial anesthesia shows definitive superiority in preventing postoperative neurocognitive disorders. The data reveals the same pattern for maintenance agents. Large randomized control trials indicate no definitive cognitive advantage of total intravenous anesthesia over volatile inhalation agents. The initial choice of anesthetic agent does not dictate brain health. Patient outcomes depend on the rigorous maintenance of physiological homeostasis while those drugs are administered. Maintaining that homeostasis requires direct observation of the brain. Processed EEG monitoring is a mandatory navigation tool for vulnerable patients under general anesthesia. The precise target maintenance zone is a bispectral index, or BIS, between 40 and 60. The primary intraoperative hazard is electrophysiological oversuppression, caused by inadvertent anesthetic overdose in highly sensitive elderly patients. This continuous EEG waveform collapsing into jagged bursts separated by flat lines is burst suppression. It carries a 41% risk increase for postoperative delirium. When detected, immediate clinical action is mandated, down titration of anesthetic agents until the waveform stabilizes. Continuous EEG monitoring shifts anesthetic delivery from weight-based estimation to a precise, data-driven methodology. Beyond electrical activity, we must secure the brain's physical supply lines, specifically cerebral perfusion. In elderly or hypertensive patients, the cerebral autoregulation curve shifts to the right. To prevent ischemia, anesthesiologists must maintain a higher minimum arterial pressure, typically holding at or above 65 to 80 millimeters of mercury. Carbon dioxide levels require similar vigilance. Allowing CO2 to drop into severe hypocapnia causes cerebral vasoconstriction, choking off blood flow to vulnerable tissues. Blood glucose presents a dual metabolic threat. Both hypo and hyperglycemia independently damage the blood-brain barrier, requiring strict maintenance within a 140 to 180 milligrams per deciliter target zone. Finally, active normothermia is required. Even mild perioperative hypothermia acts as an independent risk factor for delirium. Rigorous management of MAP, CO2, temperature, and glucose directly protects the vulnerable brain while maintaining systemic stability. We combine these physiological guardrails with targeted neuroprotective pharmacology to actively mitigate surgical stress and neuroinflammation. Watch how these neural cells react to dexmedetomidine. Its alpha-2 agonism mimics natural sleep pathways and actively inhibits inflammatory microglial activation. It is administered via a continuous intraoperative infusion, though the loading dose is often reduced or omitted in geriatric patients to prevent severe bradycardia. Esketamine, an NMDA antagonist, can also be introduced to limit neuroinflammatory markers while providing profound opioid-sparing effects. Just as important as what we administer is what we withhold. Routine opioid-heavy analgesic strategies severely compound cognitive risk. The American Geriatric Society warns strictly against the use of short-acting benzodiazepines, correlating their use directly with higher rates of delirium. Furthermore, the opioid pethidine, or meperidine, is explicitly prohibited in any vulnerable brain protocol. Building a neuroprotective matrix requires simultaneously adding specific anti-inflammatory agents while ruthlessly eliminating drugs known to provoke delirium. The clinical timeline then moves into the immediate postoperative period within the PACU or ICU. Here, the ABCDEF bundle forms the structural foundation of postoperative brain recovery. A, B, and C dictate awakening and breathing coordination, alongside a precise choice of sedatives, specifically favoring propofol or dexmedetomidine over midazolam. D stands for delirium monitoring. Care teams utilize the highly sensitive 4AT scoring system multiple times a day to catch cognitive fluctuations early. Finally, E and F require early mobility, such as sitting the patient up on day 0, and active family engagement at the bedside. Executing the ABCDEF bundle replaces the concept of passive recovery with an aggressive, structured defense of the patient's cognitive baseline. When a patient does develop established postoperative delirium, the management strategy remains highly specific. Environmental optimization vastly outperforms pharmacological treatments. Restoring natural circadian rhythms, ensuring natural light exposure, and immediately returning a patient's hearing aids and glasses are the frontline interventions. Antipsychotics like haloperidol do not cure or shorten delirium duration. They are strictly reserved for managing severe safety risks or violent behavior. Brain protection is a chronological continuum. It begins with phenotypic screening in the clinic, relies on strict EEG and physiological control in the OR, and finishes with non-pharmacological scaffolding in the ICU. Preventing irreversible cognitive decline requires the flawless execution of this comprehensive, multi-stage clinical pathway, rather than reliance on any individual medication.